So I'm now going to transition into introducing our speaker for today's session. Dr. Paxton Bach is a clinical assistant professor in the Department of Medicine at the University of British Columbia and a general internist and addiction medicine physician at St. Paul's Hospital in Vancouver, British Columbia. He additionally serves as the co-medical director for the British Columbia Center on Substance Use and is the director of the BCCSU Clinical Addiction Medicine Fellowship Program. His research interests lie in the area of opioid and stimulant use disorders with a focus on epidemiologic trends and the development of evidence-based treatment strategies. Dr. Bach is certified as a specialist in general internal medicine through the Royal College of Physicians and Surgeons of Canada and as an addiction medicine specialist through the International Society of Addiction Medicine and the American Board of Preventative Medicine. He is supported by a Health Professional Investigator Award from Michael Smith Health Research, BC. So we look forward to your session and welcome Dr. Bach as our speaker today.
Thanks, Chris. Thanks for the invitation to be here. Maybe I'll just, good morning, good time is it? Because it's closer to noon for you guys. It's still morning here in Vancouver. Thanks for the invitation to be here. It's a pleasure. I'm really happy to join this group and talk a little bit about some of our experiences here in Vancouver and the west coast of Canada, which is unfortunately sort of the epicenter of the overdose crisis in Canada, and one of the places where we've been unfortunately dealing with fentanyl and the consequences of fentanyl for longer than most. This all started here back in 2014, 2015 for us, and it's just steadily getting worse. So I'm going to talk today about, I was asked to speak sort of specifically to safe consumption sites, or safe injection sites, or supervised consumption sites, or which I'll speak to in kind of our history in Vancouver. I'm going to use this as a chance to sort of platform a few other harm reduction interventions that we've implemented, in some cases more broadly in British Columbia, and in some cases in more of a pilot program. So we'll skate through a variety of things here, and I'm happy to answer questions or have a discussion on any of this at the end. So as Chris mentioned, I'm an internist by training. I work at a hospital. I'm coming to you from the hospital, from St. Paul's Hospital right now, which is in downtown Vancouver. It's a hospital right in the downtown of Vancouver. For those of you who've been here before, it's adjacent to the area of Vancouver called our downtown east side, which is our sort of more impoverished area. It's a very densely populated, quite poor area with high rates of substance use, high rates of mental health diagnoses, and high rates of homelessness. So that is the context where I'm coming to you from, but I do work in a variety of capacities around our province, so urban and rural settings. I kind of unfortunately see a little bit of everything. So I'll begin just by acknowledging I'm coming to you from the traditional unceded territories of the Coast Salish people, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm very grateful to live and work and raise my family on these lands, and I'm very thankful to the traditional people and their stewardship of this land. I have no conflicts of interest to declare, aside from the fact that I do work in what some would describe as the epicenter of the overdose crisis in Canada. So I have a vested interest in a lot of these projects, just from a work capacity. This is the outline today. This is what I'll talk about. So again, we'll start off by talking a little bit about supervised consumption sites. So we'll explore the history of those, the brief history of those in British Columbia, the province that I'm situated in, as well as the rest of Canada. We'll talk a little bit about some of the evidence behind supervised consumption sites and sort of where they might fit in a comprehensive response to the overdose crisis. And then from that, I'm going to pivot a little bit and talk a little bit about some other novel harm reduction interventions that are being implemented. Again, some in more of pilot programs and some more broadly, in an attempt to try and reduce overdose deaths. And hopefully we'll have plenty of time for discussion. Just by way of background, I don't need to belabor this, but we're in the midst of a North American overdose crisis, which continues to get worse every single year. In Canada, BC, British Columbia, here on the far left side of your screen and the far west coast is the most badly affected province. We in our province, we lose about 6 to 7 British Columbians per day, and we have lost 6 to 7 British Columbians per day every day for almost the last 5 years. Those are friends, colleagues, family members, fellow citizens, and it's just enormously tragic. And the trauma that this is inflicting, especially on some of our more vulnerable, marginalized communities, is just incalculable, and will unfortunately it'll echo for generations. I do work in Vancouver, and I do work in the downtown east side, which has I think, an oversized place in people's minds in Canada. When people think about substance use and the overdose crisis, they often think about Vancouver, they think about the downtown east side. This here is a map of BC, of British Columbia. Now, we're a fairly large province with where most of our population is pretty densely contained in that far bottom left corner, right at the very bottom of your screen. That's where the bulk of people in British Columbia live. But this is just to highlight that, while the downtown east side is certainly an area that has many challenges, this is a province-wide issue. And if we're looking at rates of death per capita, we're not too dissimilar to you. Unfortunately, we're more than 40 deaths per 100,000 individuals, sort of all across the province, in almost every section of our province, urban centers, rural centers, northern centers. It really is affecting every corner of our province, which again is I'm sure quite similar to your reality. This is a figure representing overdose deaths per year for the last 20-some years. So you can see that from the mid-90s up until the mid-2010s, we had a relatively steady rate of overdose deaths. And then, as you're all aware, here it started around 2014, 2015, things started to change, and they started to change quickly, and have not corrected since then. So everything changed when fentanyl arrived here, which, as I said, was first seen around 2014, 2015, and really became the predominant part of our drug supply as far back as 2016. In 2016, this is when an actual public health emergency was declared by our by our provincial health officer, and that public health emergency has continued to this day. And yet, despite that, every single year is worse than the one before. 2019 be the only exception there. This is a figure from our coroner service. They put out monthly death reports for all the overdose decedents in the province. And so again, this just demonstrates drug types relevant to death over time. It's kind of looks like a bowl of noodles, but there's a couple of things I just want to highlight that are not a surprise. So as far back as 2015, fentanyl has been the most common drug type found to be relevant to drug deaths by our provincial coroner service, and that is in 90% plus of overdose deaths at this point. So this really is a fentanyl issue. But a couple other ones that I want to kind of highlight here that sort of get lost in the mix. This purple line represents methamphetamine and amphetamines. Vancouver is always a cocaine town. Like back into the 80s, 90s, 2000s, it was always a cocaine and crack cocaine town. And you can see that that's really changing over the past decade. And that purple line is steadily snaking upwards over the past decade, and is now quite prominently represented in overdose deaths. And lastly, and more recently, and also very concerningly, are benzodiazepines. Benzos were not particularly common up until the last 3-4 years, and starting in about 2019, really taking off. And then benzodiazepines have infiltrated our drug supply, much like fentanyl has. Anywhere from 20 to 50% of the drugs tested in our province in any given month now contain benzodiazepines or benzo analogs, and they're becoming an increasingly common contributor to overdose deaths as well. In the range of 20 to 30% of overdose deaths involve benzodiazepines at this point, often inadvertent, often mixed in with drugs, and people being exposed to them without their knowledge. So things are really bad. Yeah, this is largely attributable to a toxic drug supply. This toxic drug supply is evolving quickly, and we are unfortunately losing ground. That is a rather pessimistic overview, but that's just sort of where we are at right now. So now that I've sort of set the stage a little bit, we'll go to the some of those learning objectives, and we'll start by just talking about supervised consumption sites and just their rather brief history in the province of BC. Some of you, maybe many of you, I don't know, may have heard of Insight before. This was the first consumption site published in North America. This is a photo of this rather nondescript building on East Hastings Street in Vancouver, near Main Street, in sort of the heart of the downtown east side. So green storefront, much like every other along the way, but it does have a rather prominent place in the history of Vancouver, especially amongst people who use drugs, people who are and advocates for people who use drugs. Insight was established as in 2003. That was when this place first opened, and it has been running 7 days a week ever since then. Insight is, like I said, it's a rather boring looking storefront. It's a little green building. Not really remarkable anyway. And inside, you can see a picture here of the injection spaces. You can see it's comfortably lit, but they have a spotlight over each of these little injection booths. Clients can come in the front door of Insight. They register with a handle, so you don't need to provide identification. You don't need to provide any health information. Nothing is tracked, but you are asked to provide what's called a handle, which may be your name or maybe a pseudonym that you use, so that they can track. They do collect data around who's using the site and what they're using. Again, it's not linked to any specific individuals. So you provide a handle. You can then access clean supplies if you need them. So syringes, alcohol swabs, sterile water, cookers, you name it. They're all provided on site. You're led to one of these booths. You have 15 minutes, so you can spend time at the booth doing what you need to do. And then when you're done, there's I don't have a picture of it here, but there's another room in the building called the chill room, where people can go and kind of sit and relax, sit on a couch and spend a little bit of time there as long as needed before leaving. It's all rather boring. It's rather routine. It's not really not. It's exciting to visit because of what it represents, but it actually, when you come and see it, it feels not quite like a clinic space, but it's all rather routine. And many of the people who use Insight have been there many times and are well known to the group there. There are a few other resources or things that are available at Insight that have been added over the years, including a space upstairs on top of it called On-Site, which is a detox facility. So for somebody who's in Insight who wants to access detox, they can literally walk up the stairs and access On-Site and stay there if that's what somebody is seeking. And we also have drug checking now in more recent times available at Insight for people to check the drugs and actually see what it is that they have and what it is that they might be using. And that's really kind of all there is to it, despite many urban legends and much fanfare over the years. Just to give you a sense of kind of what people use there and how frequently it's used, this is injections per month for between 2004, just shortly after Insight opened, up to 2015. And you can see that by far the most common substance used at Insight over the past 2 decades has been heroin. And this ends at 2015, so fentanyl was starting to creep in there. At that point, most people still believed that they were getting heroin around that time. So this doesn't include fentanyl as its own specific thing on this graph, but it tends to be heroin, or what people perceived to be heroin is the most common thing. That was followed closely by cocaine for many years, up until kind of the early 2010s, when you can see cocaine, that purple line started to trend downwards, and methamphetamine, that orange line, started to trend upwards. And since about 2013, 2014, methamphetamine has surpassed cocaine as the most common stimulant we see used at Insight and also elsewhere. You can also see here we're looking in the range of per month, like 5,000 to 6,000 injections per month. So it is a rather busy place. briefly, just kind of to talk about the history of Insight and where it came from, how it got started. This is not going to do the story justice, because it's actually quite a fascinating story, and we owe a tremendous amount to some really outspoken drug user activists from the 90s and early 2000s, who are still around to this day, and I count as good friends of mine, and some rather brave elected officials as well, who really stuck their neck out around that time. The BC coroner in the late 90s, our mayor in the early 2000s, really committed to this, and really were the reason that Insight exists, driven primarily by that community advocacy and activism, but supported by some elected officials who, unfortunately, some of them did affect their careers, but it was felt that this was important. So, as I mentioned, 2003 opened in 2000, or sorry, Insight opened in 2003. It was the first ever legal supervised consumption site in North America. And it was created through something called the Section 56 exemptions. I can't really speak to the US context and the regulatory models for these things, but this was a federally granted exemption from Canada's Controlled Drug and Substances Act that allowed for possession and utilization of illegal substances on the grounds of this site. So that exemption is what led to the creation of Insight and allowed it to function as a legal operating site. That was preceded by a number of services in the 80s and 90s, mobile needle exchange services, but would date back to the 80s, and several sort of unsanctioned safe consumption sites created by activists and street nurses through the 90s, which were what would pop up and run for a period of time and then frequently be shut down. And again, a lot of conversation primarily from activists and really outspoken advocates from the community people who use drugs, and a variety of politicians and public health professionals who lended their support as well, with the idea of treating substance use as a health issue and not a criminal one. You may or may not be familiar with something called the 4 pillars approach to drug use, which is sort of become a bit of dogma in Vancouver. That was adopted in the late 90s as an official approach from the city of Vancouver, which focused on 4 pillars: treatment, prevention, harm reduction, and enforcement. And the 4 pillars approach, or a version of that, persists to this day. All was not well once they established this site, though. It's not that it has had its own share of controversy, and that largely began in 2006 when our federal government changed over to a conservative majority. So we had a liberal government in place when Insight was established, and then our federal government changed to a conservative one, who were not shy about their opposition to Insight, and in fact actively tried to shut it down not long after taking power and that Section 56 exemption. This went to court. This was challenged. So in 2008, it went to the BC Supreme Court, and they ruled against closure of the site. That was appealed by the federal government. So it went to the BC Court of Appeal in 2010. They once again upheld the decision of the BC Supreme Court from 2008. Then it went to the Supreme Court of Canada, again brought by the federal government. And in 2011, the Supreme Court of Canada ruled unanimously against revoking the exemption. And this is the exact statement from the Supreme Court of Canada at that time. Withdrawal of the CDSA exemption was felt to be arbitrary and undermined the very purposes of the CDSA, which include public health and safety. It was also grossly disproportionate. The potential denial of health services and the correlative increase in the risk of death and disease to injection drug users outweighed any benefit that might be derived from maintaining an absolute prohibition on possession of illegal drugs on Insight's premises. Pretty strong language from the Supreme Court of Canada. And so this really was kind of the final nail in the coffin as far as legal action to close Insight. But despite that, it has, Insight has become just a part of the community. But the concept of safe consumption sites is still a very polarizing and controversial one in Canada. This is timely because it was only 3-4 weeks ago now that Insight actually celebrated its 20th anniversary, and so there was lots of excitement around that. And lots of celebration. It does feel like yesterday that this started. I remember this vividly. I was in undergrad at the time. Just want to again highlight. So this has been the trajectory, unfortunately, of overdose deaths in our province over the past 20 years. That public health emergency, as I mentioned, was declared in 2016. So the provincial health officer declared the overdose crisis to be a public health emergency. And the reason I highlight that is allowed for certain powers under the umbrella of a public health emergency that the provincial health officer then gets to take on. And now we're going to get this may sound a little bit pedantic, but we're going to get into the difference between a supervised consumption site, i.e. InSite, versus an OPS or an overdose prevention site. So a supervised consumption site, such as InSite, is quite a specific thing. It's a brick and mortar facility which has received an exemption by Health Canada, by our federal government, under Section 56.1 of the Controlled Drugs and Substances Act. It involves quite an elaborate and complex application. It includes a plan for operations and consultation with community partners. It's required to have a whole network of support service, including nurse staffing and et cetera. And it's not an easy thing an easy process to go through. But once you have achieved that, as long as you're able to maintain that exemption, there's permanency to supervised consumption site. It is a rather permanent thing. The declaration of a public health emergency in our province gave the PHO, our provincial health officer, increased powers, including to sanction what has since become termed an overdose prevention site. So an overdose prevention site is different from a safe consumption site in terms of kind of how it comes to be. An overdose prevention site is much more it's much more bare bones. So these are community-based responses to a public health emergency that can be established by an order from the provincial health officer and really don't require any of that same paperwork in order to set them up. They simply require a thumbs up from the public health officer who has these powers in the context of a public health emergency. They're meant to serve a very immediate need in the community. They're often peer run. They're quite bare bones. They often sometimes it might be an ATCO trailer or maybe even just a tent, a table and some chairs. They're generally peer run. They often don't have the same kind of a network of support services that a supervised consumption site might have. And the infrastructure is often quite minimal, but they can be established sort of wherever the need is perceived on fairly short order, with the expectation that they're not meant to be permanent, although given the duration of this overdose crisis, many of them have been there for quite some time. So the end result for somebody who's using drugs is still a place where they can go get their drugs checked, potentially use drugs, and have somebody there to help them if something bad happens. But the way to get there is quite different from a regulatory standpoint. In the context of a public health crisis, there has been a pretty significant upscaling of these type of sites in our province. And this is British Columbia. You can see from this map, all those little blue icons down in the bottom left of our province represent sites, whether they're safe consumption sites or overdose prevention sites. See, we have 5 supervised consumption sites in our province, and somewhere between 35 and 40 OPS, although that number fluctuates as they open and close, largely concentrated in those more urban areas in the lower mainland of Vancouver and on the southern Vancouver Island. Far less resources in rural BC and in northern BC. So it has been an approach that's been embraced by the province, but I would say it's limited in what it can accomplish. This is just an article from last year that I like to highlight because this is in the Vancouver Sun, our local paper. It just highlights Canada's first in-hospital overdose prevention site, which is here in St. Paul's, just down the hall from where I am right now. So we have a small overdose prevention site within the hospital itself for patients who are admitted to hospital who continue to use unregulated drugs. So they're not overdosing in a bathroom or an elevator or a stairwell or out in the patio or in the back alley. So this is staffed by nurses. This is open throughout the day, and patients can come access safe sterile supplies and use in a safe place here within the hospital if needed. So that's really the history that I was going to touch on. So again, InSite, the first safe supervised consumption site established in North America. It's been running since 2003, but there's a pretty strong precedent here of European models, which I didn't touch on. This is not something that we've invented on our own. There's certainly a precedent there. Numerous other sites have opened across Canada and New York since then, with a very significant escalation since the beginning of the overdose crisis, including the power to open overdose prevention sites. And until 2023, there had never been a reported overdose death at a supervised consumption site. And anywhere in the world, to my knowledge, that has unfortunately changed. I'm aware of at least 2 deaths in the past year at supervised consumption sites, which is just really tragic and speaks to the complexity of the overdoses that we are now seeing in the current in this current era, which are really an order of magnitude more challenging to manage than they ever have been. So that's learning objective number one. I don't see anything in the chat, so I'm just going to keep going on supervised consumption sites. As I said, I think we'll have more chance for discussion at the end of this. So the second objective here is to talk a little bit about the evidence behind supervised consumption sites and where they might lie in a comprehensive response to the overdose crisis, because that's always sort of the next question. So to paraphrase, do supervised consumption sites, quote unquote, work? That is a question I am asked often. I'm not really going to go into huge detail, like an expansive review of the evidence here for lack of time, and really I think it's, well, here's one paper that I'm going to highlight. So this is a systematic review back from 2014, and really the reason I'm not going to go into this in great detail is the literature is pretty conclusive here. It's pretty overwhelmingly positive. So this systematic review, which was from almost 10 years ago now, included 75 articles looking at the impact of supervised consumption sites in Canada, Europe, and Australia. And they're almost universally positive. Almost universally, any outcome you look for, benefit can be shown. So incidence of HIV and hepatitis C declined significantly in Vancouver with the opening of Insight. The sharing of needles decreased. Clients who accessed Insight were more likely to access other treatment services, detox facilities, and opiate agonist treatment. Overdose death rates decreased at the site and in the surrounding area around the site. Public injection drug use decreased. There's been in multiple settings no increase in crime or violence or drug trafficking or public safety in general in the surrounding areas around supervised consumption sites. Cost benefit estimates range pretty widely depending on where they're being done and kind of what factors are being included. But the cost benefit is estimated to save anywhere from $3 to $25 million annually with the running of one of these sites. And in general, when you pull different communities, again in Canada, Europe, and Australia, somewhere between a significant majority to the vast majority of surveillance in these surveys are in support of the concept of supervised consumption sites. So really, kind of any outcome you can think of, you can find literature speaking to the positive impact of a supervised consumption site on that impact. And it's really hard to. I'm not going to spend much more time on the evidence because of this. From my perspective, it's rather conclusive to me at this point. For people who are using these sites and for people who are in the immediate area surrounding these sites, it is very, very hard to argue that the impact isn't overwhelmingly positive. The question, though, becomes when people ask this is, what do we mean by work? What does it mean by the supervised consumption of this work? What that question is doing a lot of heavy lifting and in fact, I get asked this question a lot, kind of more broadly, where people say, does harm reduction work? And that's a really deceptively tricky question, because harm reduction is not any one thing, as you're all aware. It entails a whole philosophical approach and a number of different types of services, and we need to be really specific and thoughtful when we're answering this, because there's lots of misinformation that's out there. What is meant by work? Do supervised consumption sites reduce risk of overdose death for people who are using them? Absolutely, they do, without a doubt. Do they reduce risk of HIV and Hep C in people using them? Absolutely. But we need to be quite specific, because unfortunately, one of the criticisms of such sites is that we've established them and rolled them out fairly widely in our province, and yet things continue to get worse every year. So some people try and argue that this is evidence that they're not working. And I think that's disingenuous, personally, because they can be very effective for people who are accessing, but as a population level response to a crisis of this magnitude that is affecting people all across the province in every tier of socioeconomic status in every corner of a province, they are not a sufficient response. We're not seeing that public health impact from supervised consumption sites alone. And I think it's disingenuous to expect that you would, considering how many people out there are using drugs regularly, periodically, in private residences, in a variety of different settings. So I really push back on that question and ask people to be very specific when they ask me things like that, because often as not, there's an agenda behind a question like that. This is just an example, though, if you want to, of another study that you could point to, and when asking again, do they work? And if our crisis isn't resolved, how can we justify that they work? This is a modeling study from 2019 from British Columbia, looking at the combined impact of a number of interventions on averting deaths during the earlier phases of overdose crisis. This goes back, just goes up to 2017. And there's a few different things here. I just want you to put this is deaths by quarter of the year, so by 3-month period. This kind of purpley blue that I've circled is the overdose prevention sites here. So based on some pretty sophisticated modeling that's done by our Center for Disease Control here, it's estimated that back in 2016, 2017, early days of the crisis, that overdose prevention sites were saving somewhere between 50 to 100 lives per quarter in our province. So anywhere from 200 to 400 overdose deaths prevented per year, thanks to the upscaling of overdose prevention sites. So do they work, as in have they ended the overdose crisis? No, and I think that's unrealistic to that expectation. Do we have reasonably good reason to think that they've prevented hundreds of overdose deaths in the context of a crisis that's bigger than that? Absolutely, we do. The highlight here is just that existing treatment and harm reduction approaches can be effective, but alone they're insufficient. We need more. We need more than just a handful of overdose prevention sites. It's not all like roses here. Despite the fact that Insight's been around for 20 years, these sites do remain very controversial and are often in the media. This is again from the Vancouver Sun. This is a different supervised consumption site in our community, kind of adjacent to the downtown east side, which is being shut down because of a lot of community opposition. In Alberta, the province immediately to the right, the future of supervised consumption sites in general remains in doubt. There's much more opposition by the elected government in Alberta to a variety of harm reduction interventions. This is a paper from Ontario, where funding set to expire for a site in Sudbury, Ontario, in Northern Ontario. So it's not as if the doors closed. They remain, unfortunately, still tenuously funded and controversial in Canada, despite, as I mentioned, our evidence that from my perspective is pretty hard to argue with. Why is this the case? Well, you'll hear all sorts of arguments, and all of them kind of ring a little bit. They're all a little thin to me, but most commonly you'll hear things like whether this is the best use of limited resources, whether they could be put into something else. Just based on the cost-benefit analysis alone, I push back on that. Community acceptance is unfortunately a huge one. In the abstract, many people are supportive of these, but they don't necessarily want them in their communities. Is there a potential for unintended consequences with new sites? Just reviewing, I'm not sure I got cut off there, but just reading the rationales. Unfortunately, probably the most common rationale really comes down to moral opposition or philosophical differences to the establishment of such sites, which is an ongoing barrier in some places more than others. So then, just to summarize, and again, we can talk about this at length afterwards, but the evidence exploring the efficacy of supervised consumption sites at reducing various harms is extensive. But as a response to the overdose crisis, they themselves have been insufficient to change the course of steadily increasing overdose deaths at the scale that we are seeing. And as I mentioned, despite what I would consider, and this is my own bias, I suppose, coming forward, I would consider overwhelming evidence supporting their positive effect on a variety of individual outcomes, they do continue to remain a controversial intervention, as do many things in the in the realm of harm reduction. I see one question here. I can quickly speak to what type of professionals are employed at the supervised consumption sites. The supervised consumption sites have nurses, or some of them have nurse practitioners as well. Overdose prevention sites are peer-run. Physicians are not present at the, not mandatory at an SCS, and often not present, but do come. One of my colleagues is an ID doctor who comes there and does consults at the SCS to treat infections. The detox, as I mentioned, that's above Insight. On-site is the name of the detox. That has a physician associated with it for the medical detox there. So it's not mandatory, but can happen. And is the drug they're injecting monitored by staff in order to ascertain strength? I'm not sure. Like they do say what they're injecting, what they think that they're injecting, and there are drug checking services there they can utilize if they want to. Unfortunately, as you're probably aware, many of the drug checking services are not quantitative. They will just say merely whether there's a presence or absence of certain substances in it. Although we do actually have some quantitative apparatuses in certain settings in the province. So. But in general, it's all that's all optional. That's all whether somebody wants to have their drugs checked, they're welcome to. It's certainly not mandatory. Although they are asked to record what they believe that they are using. So lastly, and here this is going to be like a rapid fire, so I'll go through this one just to kind of float some other interventions that we are trying, just to put them out there. And again, I'm happy to talk about any of these in length, but we'll talk about a number of other harm reduction interventions. This is not a comprehensive list, but some that I am involved in or have a particular interest in. And these are sort of the ones that I'll highlight today. Starting with, if we go back to this paper, I showed you this before. We talked about the number of deaths prevented with overdose prevention sites, but there's one intervention here that you can see is most prominently represented in this figure in terms of the amount of overdose deaths that it's modeled to have prevented, and that's take-home naloxone. So take-home naloxone problems. So take-home naloxone, I know, is something that's gathering steam in the U.S. in a variety of places. I'm not sure what it's like in Kentucky, but it's something that we adopted fairly early in the province. I'd say I'd say our system is for that is one that I'm relatively proud of. So take-home naloxone in our province was really rolled out quite early. Started back in 2015 and with rapid scaling. By mid-2023, where this figure on the left comes from, nearly 2 million naloxone kits have been shipped around our province and distributed in a variety of sites. There's over 2,000 distribution locations in BC, and you can access a naloxone kit in any of those sites for free, including correctional facilities, hospitals and emergency departments, over 800 community pharmacies in a variety of First Nations communities as well. So almost 2 million naloxone kits shipped since 2015 in our province, which is not a particularly populous province. We do ask that people report if a kit has been used. Okay, the question on naloxone kits, again, do they work? Very important aspect. That means, does a naloxone kit help to prevent somebody who's using drugs from dying, like during an overdose? Absolutely. Is this a sufficient response to an overdose crisis that is complicated and has so many drivers to it? No, I would never argue that it was. But I think that the efficacy of naloxone at reversing overdose deaths is pretty inarguable, and this program has been quite a success. I've mentioned drug checking a number of times, and I have mixed feelings about drug checking as an actual harm reduction intervention, but it's something that, again, we do have a fairly robust drug checking program in our province. And all these results are, if you're ever interested, are all publicly available on this drug checking dashboard. So looking at, you could use this dashboard by date range, by geographic location, by type of substance checked, and get a real-time sense of what drugs are out there. Which I think is still powerful information. It is tied, at least in the Lower Mainland, to a drug checking warning system. So anyone can sign up for this, where if particularly bad drugs are checked at any of our various drug checking sites, a text message goes out to anyone who signed up to give a heads up regarding, as you see, bright blue chunks tested positive for fentanyl and for flualprazolam, or a light yellow powder tested positive for fentanyl and flualprazolam. The bottom two here are highlighted in red because they're particularly scary. These are counterfeit Xanax bars and white powder sold as cocaine, which both tested positive for benzos and fentanyl. So they weren't even being sold as opioids, which is just terrifying. But we do have this drug checking system in place in the Lower Mainland, accompanied by text messages. It also gives us a pretty good epidemiologic sense of what the trends are in our province, especially when combined with that coroner data I talked about earlier. Drug decriminalization is something I have to touch on because it keeps coming up because of Vancouver, BC, we're the home of the great experiment, much like in Oregon. It's often described as an experiment, which I push back on. But BC decriminalized opioids or small amounts of opioids and stimulants at the beginning of 2023, and has received a lot of press for doing so. Drug deaths haven't changed since the beginning of 2023. So often I get again asked that question: does decriminalization work? And once more, I ask what you mean by work. What is the purpose of drug decriminalization? And is it actually reasonable to expect this to prevent overdose deaths, at least in the short term? What would be the decriminalization of personal possession of substances? What would be the mechanism through which that might reduce somebody's overdose risk? People may be more willing to be upfront about their use or to use at a safe consumption site if they're not going to get persecuted for it. But I think it's rather unreasonable. There's not a really an easy mechanism to see there where the decriminalization should have any direct impact on overdose prevention. Rather, what I would propose is that the decriminalization of personal possession of substances over time will help to reduce harms and stigma associated with substance use, and give us the space and the resources, for that matter, to refocus on more effective strategies in order to develop a more comprehensive and evidence-based public health informed approach to substance use and its harms, rather than the continued criminalization of substances and people who use drugs. Through that, I would hope that we will ultimately see that effect on overdose prevention, but that is a long game. That is nothing to expect to happen in 6 months. And so you'll see lots of media talking about the fact that we've gone through decrim and drug deaths, overdose risks haven't changed. And again, I think it's really important that we're very specific about what outcomes we're expecting from these interventions, and what both in the short term and long term. Because drug decrim it comes up a lot these days in Canada, and it's a bit of a dog whistle, or I shouldn't say dog whistle, but it's emblematic of sort of discussions around harm reduction in general. I'll just mention briefly, we have a little bit more access to medications for the treatment of opioid use disorder in Canada than the US, or different access. I should say we have 3 different oral options, including methadone, including buprenorphine, including slow release oral morphine, which is the treatment that's available here. We also have injectable opioid agonist therapy programs, which are pretty well evidenced and pretty widely available in urban settings in Canada. But as an addiction medicine provider, I still feel like we're lacking tools, and there's a variety of novel treatment programs which are being piloted in studies, including the use of fentanyl patches as a long-acting form of agonist therapy, including various fentanyl products, other fentanyl drugs like Fentanyl buccal tablets or sufentanil, to see whether there are rules for these as forms of agonist therapy, and diamorphine or diacetylmorphine or prescription heroin is another thing that's available in certain settings in Canada, and is being piloted in other settings for other uses. So a variety of novel agents are being tried, mostly in sort of research context. The last thing that I'll touch on, and I could talk for more than an hour on the subject itself, it is the biggest controversy in addiction medicine in Canada at this moment in time, and I'm not going to do it justice in the time I have to talk today, but I feel obliged to at least introduce the idea for those who haven't heard of it or heard rumors of it, is the concept of a safer supply. A safe supply or safer supply of substances, which is a term which has been around for quite some time, but has really taken over and dominated the conversation in addiction medicine in Canada for the past year or two. The concept of safer supply, the idea behind the idea of safer supply, is really kind of I think summarized here. So some of you may have seen the Stanford Network on Addiction Policy publication from earlier this year. Brennan Gibbs and Keith Humphreys. This is just one statement that's taken out of it, which I think is really important for us to all recognize. I think it's not news to anyone here, I'm sure. although I guess I can't speak to the Kentucky context, but in Canada, this is not news to anyone working in this field, but it's still news to the general population, is that increased harms and the overdose rates are not the result of an increase in the user base for illicit drugs. The rates of addiction have not skyrocketed in the past 10 or 20 years in Canada. The increase in opioid-related harms in Canada is being driven almost exclusively by the increased toxicity and unpredictability of the drug supply itself, rather than any increase in the number of drug users in the general population. This is a supply issue. This is an unregulated, unpredictable, volatile, rapidly evolving drug supply. That is the proximal driver for overdose deaths, and that's fairly inarguable. So the potential answer to that, that has been put forward again by a lot of drug user activists, is providing people with a safer alternative, with essentially a regulated drug supply. The term safer supply is catchy and alliterative, but essentially it's referring to a regulated drug supply or regulated alternative to the toxic drug supply. Being proposed by a lot of drug user activists, and is being piloted again in a variety of settings in a variety of different ways. In British Columbia, we have been sort of the early adopters to this policy, and there's actually a provincial policy around prescribed safer supply as a potential harm reduction intervention to the toxic drug crisis, which with accompanying clinical guidance on how this can be operationalized in different settings, if the desire is there. The idea behind, again, prescribed safer supply it's rather, I mean, the concept is a fairly straightforward one. The problem is that poisonous drug supply is not rates of addiction. So if you can provide people with an alternative to use, then at least takes that unpredictability off the table. It speaks to sort of this bigger idea, which is termed the paradox of prohibition, which I think is a really important concept to kind of understand. The paradox of prohibition states that with any substance, opiates, stimulants, alcohol, tobacco, you name it, that the overregulation, which is represented on the far left here, the furthest to the left in terms of regulation would be prohibition itself, or the underregulation, which is represented on the far right, which is legalization, active marketing, and promotion. That with the overregulation or the over promotion of any substance, you will see increasing harms, and that finding that middle ground, where which is that this is represented in a parabola here, but this typically the shape is going to look very different for any different substance based on its own properties, but that we need to find a space for any substance between the over regulation of prohibition versus the active legalization, promotion, and marketing, and kind of find that the bottom of the curve for any given substance. And we try and do this with tobacco, we try and do this with alcohol, and that we could do the same with opioids as well. I would argue that tobacco and especially alcohol are far to the right on the spectrum right now in terms of the level of promotion that we see, the level of normalization and the harms that ensue from that, and that opioids are on the far left, and we could use this same framework to kind of inform our thinking about a variety of substances. But this is the concept behind a safer supply or a regulated drug supply, whether we can find the bottom of this curve. So this has been piloted in British Columbia with primarily some prescription opioids and prescription stimulants, hydromorphine and morphine, dextroamphetamine and methylphenidate, which are available from prescribers, usually addiction medicine prescribers in certain settings, not for the purposes of treating an opioid use disorder, but simply to provide people with an alternative to a highly unpredictable drug supply. But there's no mechanism in place to distribute things like actual fentanyl and cocaine and crystal meth, and you'll read a lot about this in the media, but it's still relatively narrow in its scope in our province. The most obvious concern or potential unintended consequence that is articulated by people who are either skeptical or opposed to these programs goes back to what we know about opioid prescribing in the early 2000s in Canada and the US, where opioid sales and opioid addiction and death rates all increased in lockstep over that time, largely due to overprescribing. Although I would argue that overprescribing is not it does not explain the entire picture. But we know that increased rates of opioid sales correspond with increasing rates of addiction. We also know that prescribing rates in the US have been on the decline since about 2011 or so, and yet that certainly has not corresponded with decreased rates of addiction or overdose deaths over that time. So there's a bit of an uncoupling that has occurred. But this is a very real potential unintended consequence that is an active point of discussion. And yet, if we look at the rolling out of prescribed safe supply in certain areas of our province, there's approximately 4,500 patients who are actively accessing a quote unquote safer supply or regulated prescribed supply of hydromorphone in our province. There's been no detectable effects among those individuals or more broadly about increasing rates of opioid use disorder or overdose deaths attributable to hydromorphone. And the best data we have, which is quite limited so far, I will be the first to say, does suggest that there is a protective effect for those who are accessing prescriptions on overdose death, hospitalizations, and retention in traditional forms of opioid agonist therapy as well. So early days, and you will hear far more about this, I am sure. We have no data for prescribed stimulants because frankly, no one's accessing them. Health Canada has done an evaluation of this that's more qualitative, and they've gone to people who are accessing these and asked them how it has affected them. And the qualitative evaluation of these programs has been really overwhelmingly positive. People who are accessing these substances really do talk about the stabilizing influence that it has on their life. But many outstanding questions remain, and about positive, negative, and other unintended consequences. It is early days. So I'm almost done. The last thing I'm just going to say, this is my closing parable before we open it up for questions. Is just this is the Skeena River. This is northern BC. This is where I grew up. Many of you probably are familiar with. I often get asked, like, okay, does harm reduction work? Do you see supervised consumption work? Like, what is the solution? What is the solution? Which is obviously a really complicated question, but many of you may have heard the public health parable before of river, of a person who's walking alongside of a river, and they hear a noise and they look in the river, and there's a man floating by in the water, and so they go down to the shore and they throw him a branch and they help the man out of the water and they carry him and walk down the river. And shortly later, there's another man who's floating down the river, and once again, they go down to the riverside, they throw a branch in the water, they help pull the person ashore, carry him up a walk, and sure enough, 5 minutes later, another person floating down the river. It does not take long before that individual is going to go upstream to figure out what is happening. Why are so many people falling in the river to begin with? And that's really, I think, this is not a new concept. This is like public 101. But I think that we still, at least in my context here, lack that scope. I'm talking about the overdose crisis. When we're talking about harm reduction, we are talking about pulling an individual out of the river. And nobody would ever argue that pulling an individual out of the river is enabling them to fall back into the river again, or is not worth your time or your resources. But it's true that it does not address the reason that people are falling in the river in the first place. A lot of talk about increased access to treatment services in Canada and the US, and treatment and more treatment being the solution. And as an addiction medicine physician who refers people to treatment, who provides treatment on a day-to-day basis, I cannot argue with that. Our treatment system here is fractured. It's difficult to navigate. It's not particularly patient-centered, and there's much we can do to increase the quality of our treatment service, increase the access to our treatment service, and develop a more patient-centered, streamlined treatment system. Because frankly, ours is nothing of the sort here in Canada. But really, what we don't spend enough time talking about in Canada, and my suspicion is that unfortunately it's the same everywhere. We don't talk about the concept of demand reduction, or really going to the mouth of the river and really addressing the reason people are falling in to begin with, which unfortunately comes back to poverty and trauma. But I shouldn't say that. We will be broad and will be highly individualized, but we'll often, not always, come down to things like poverty, mental health, racism, trauma, really fundamental societal issues that we still haven't fully decided to reckon with yet. There's not nearly enough attention paid to these ideas in where I live, and I unfortunately suspect it's probably the same everywhere, because those are hard questions to ask. So again, that was a rapid fire, but I'll just highlight a number of other treatment harm reduction options are being piloted in our province in an attempt to reduce overdose deaths. The data for quite a number of these interventions is limited, but there are reasons to be optimistic about individual interventions and where they might work in kind of the bigger picture, but really a comprehensive approach involving investments in treatment harm reduction and upstream drivers of addiction is critical, and I would argue still lacking to this day. So that is our outline. So we talked about the history of safe consumption sites in Canada. We talked about the evidence behind them and where we're at right now, and how they might fit into a broader picture with some other interventions. I think we have about, I believe, half an hour still for discussions. I'm more than happy to answer any questions that anyone might have.
Thank you so much, Dr. Bach. Please feel free, if you have a question, to unmute yourself or raise your hand, and we're happy to call on you. Just looking through the chat, I know that there was a moment there where was signing off and signing back in, maybe the chat didn't show up. So I think there might have been 2 questions. I'm going to go back through, and Lisa, if you see anything that I missed, but I'll try to go back and ensure that all of the previous questions were addressed. One was regarding the text message warnings that are sent out to participants from checking the drug supply. How are those generated? Are those from technicians, and how does that information get disseminated, and how quickly does that go out from when they?
It's a good question. I don't know how fast it comes out. I mean, we get the results immediately, and the warning system is rather low tech, and fairly, it's fairly low tech. It's fairly easy, but I don't know how quickly they can turn around. I hope and expect it's very quick, because it simply involves blanket text to anyone who signed up to this text message group, and they do get those results on the spot. So I don't actually know the answer to that. And our drug checking system as a whole is there are levels to it. Many of the people who are doing drug checking on the ground, many of the technicians, many of them are people with lived experience. Others are other research assistants with the BC Center on Substance Use, or a variety of other people. There's sort of different structures to them depending on where you are in the province and what kind of technology is being used and how much training is needed for that technology. But they are all centralized eventually, and that data all comes to that website. So the individuals are actually doing the checking themselves. It can vary based on the setting, but the reporting back comes through one centralized group.
Thank you. Yeah.
Just to put, I think it was a great tool. I think it was a great idea and a great tool. Unfortunately, the reality is 95% of our opioids have fentanyl in them at this point. 30 or more % of them have benzos in them. So it's no longer really, it's not the same kind of warning that it used to be. It used to be a point where if you found fentanyl in your opioids, people were scared and they either didn't use it or they adjusted their behaviors accordingly. It used to be a point where people, if they found benzos in their opioids, they might try and dispose of them or again adjust their use. But it's so normal at this point that in the absence of being able to get quantitative results, like actual concentration of fentanyl, it's become far less useful, because now people are either actively seeking fentanyl or benzodope, or at the very least just accepting that that's what they're going to get. So as I remember asking a patient once if he used drug checking services, and he said to me, and this really sums it all up, "What's that going to tell me, doc, that there's fentanyl in my fentanyl?"
Yeah, I think that makes a lot of sense. And it is also probably limited by the substances that are being tested for and the rapidly changing substance profiles. So you're also potentially limited by that as well.
Yeah, I think it has a much more utility amongst people who use more intermittently. as drug checking services were set up at raves and other concert venues and stuff like that in the province. So for people who are not even seeking to use opioids, but perhaps using MDMA or something like that, or cocaine, which is also frequently contaminated with fentanyl, there's probably more utility in those settings. I see a question from Katrina. Oh wait, there's another question from Chris. I see your question here. Have any of these sites done studies to compare what substance people think they're using versus what is found through drug checking? I haven't seen that. That's not true. People do say what that data is available through the drug checking website. It is pretty unusual. Well, it's relatively unusual that people test something like something. Again, about 95% of opioids, for instance, are opioids, and maybe 5% of them aren't even in the same class that they're expecting. But within that, like the amount of contaminants and the speed at which that is evolving is so fast. As I mentioned, benzos weren't even a part of our landscape until about 3 years ago. Then etizolam became a really prominent part of our drug supply for about a year. Etizolam is actually a thiamidazepine. It's not a benzodiazepine, but a benzo analog. Etizolam has dropped off quite quickly, and now we're seeing a lot of bromazolam and flubromazolam, increasing amounts of carfentanil. I expect that that's going to change. The xylazine hasn't really reached BC yet, but we're starting to see it creeping up here. So it's changing so quickly that really, like clinically, it's very hard to keep up. I see a question from Katrina about options like prescribed fentanyl or long-acting morphine. How are they looking these days for supply versus opiate agonist treatment? It's a really good question, Katrina, and it depends on. I mean, there's very many different substances that you're looking at. I think of opiate agonist therapy or opiate agonist treatment very much as treatment, not as a harm reduction enterprise, but it's a evidence-based treatment. Whereas much as we're talking about in terms of these less structured interventions are more under the harm reduction umbrella. When you really start to dig down into all the different ways that these things are being implemented, there is certainly a gray area in the middle. For me, the biggest difference is sort of the amount of structure around how these are being provided. So when you see long-acting morphine, it depends. Slow release oral morphine, which is a capsule or a number of capsules that release morphine slowly over time. That's an evidence-based form of opiate agonist therapy that's prescribed in any clinic in Canada. You can access that alongside methadone or buprenorphine. We don't have OTPs in Canada. We do office-based prescribing and pharmacy-based dispensing. So you can go to your doctor. You can get put on buprenorphine. You can get put methadone in his office, or you can get put on slow release oral morphine. But it's very regulated. You start at a certain dose. You increase at a certain rate. You have to get it every day. You have to go to the pharmacy and take it as a witness dose at the pharmacy for the most part. The prescribing and administration of slow release oral morphine is really no different than we do methadone here. And fentanyl patches, which are being piloted in these programs, it's similar. You go to your doctor, you get a prescription for a low dose, you go to the pharmacy where they'll administer the patches and do the patch changes. You have to turn in your old patches to get new patches and start at a specific dose and increased quite slowly and carefully in a very kind of predetermined fashion over time. So those fentanyl patches are really quite analogous, I think, to opiate agonist treatment. It's potentially, we'll see how things go, but potentially just another tool in the toolkit as far as opiate agonist treatment goes. Things like hydromorphone, for instance, that have been prescribed under that umbrella of safe supply, I think that the key difference, distinction for me between treatment and more of a prescribed safe supplies is agency. People will get prescribed a certain amount of those hydromorphone tablets per day, but they don't have to use them in a witness facility setting. They don't have to use them in any particular way. They can take them all at once. They can take them, like they have agency in terms of what they use and when they use and how they use it. So it's really not kind of nearly as prescriptive as our sort of usual addiction medicine paradigm would be. And that is sort of to me the distinction between sort of novel forms of opiate agonist treatment and really that harm reduction lens that hydromorphone might be available in certain settings.
Great. Yeah, thank you for those responses. Just wanted to check for other questions. Again, feel free to put them in the chat or come off mute.
For anyone, I did send these slides to Lisa, so if anyone's interested in the slides, I think you can access them through her. And I'm more than happy for anyone to email me and follow up if you're looking for any resources related to what I talked about today, or if you just have any questions kind of once
Yeah,
you digest this material a little further.
Thank you. Yeah, well, or I'll absolutely share. We do share or have the ability to share the slides in addition to the recordings for the sessions, and can put the contact information in our newsletter. I was curious. We also include, other relevant links, and I was curious if there is a specific resource, or web related link to kind of keep up to date on like the piloting of the kind of safer supplies. Or do you just kind of keep looking for new research articles, or is there like
there's it's a little bit of both, but the most the research institute that I work with is called the BC Center on Substance Use. We are not conducting all of that research, but all of the clinical guidance comes from us. So the BCCSU website, which is just bccsu.ca, is probably the one place where you can get the most up-to-date information. We put out research summaries around that data periodically. We're trying to make that more regular, as well as clinical guidance and updates to the clinical guidance, both for some of those novel treatment agents, as well as some of the kind of the harm reduction interventions as well. So it's not comprehensive to every single thing I talked about today, but it's the number one kind of place to go to get much of this info.
Great, thanks so much. I just put that in the chat, and we'll include that in our newsletter when we send this out, so that people can peruse that site.
Thank you, Dr. Bach, for presenting with us today. I'm curious. I really liked that graphic with the paradox of prohibition. I tried to find it on where you said that you got the reference, and I was curious if there was like a website or a place that had that visual was so helpful to just put this all together and simplify all these different concepts.
I can't even tell you where the concept originated from, but you'll see different illustrations of it, but I can send you, Katrina, the particular figure that I got, where that's from. It's from a report from one of our health authorities here in BC. So I can send you that and follow up if you'd like.